Hi everyone, and welcome to Cardiology. This first lecture is entitled Approach to the Patient, and the goal in this lecture is to introduce you to some concepts in cardiology related to the history, physical, and some of the diagnostic tools that we use. And it's not meant to be an exhaustive introduction here. I really want to just kind of get an overview, because for many of you taking this course, some of you have more health experience than others, but many of you may not have much health experience at all. And so this is really a time where we're going to kind of bridge the gap now from some of the physiology that we've learned about cardiology and bridge that now into a pathophysiology and an understanding in the clinical context. So what I want to begin with here is just by introducing you first to a case. So this brings me to my next point, which is that in this course, unlike in physiology, physiology was more of a basic science introduction to how the different systems work and interact with one another. But in cardiology, we'll kind of assume that we understand more of that physiology already. And so if you have trouble with that, we should review that or look at some of my prior lectures. But I'm going to try to integrate more of the clinical with this. And that being said, that means you should expect that on exams or questions that I would give, that they would be more clinically oriented. So I'm trying to get your mindset to work in that manner now, as we kind of move forward. So to start us off, I want to start us with a case. And so we have a 32-year-old Caucasian man, and he presents to the clinic with complaints of shortness of breath or dyspnea, and it happens when he's exerting himself, and he has a fever. And the patient states that he was recently started on antibiotics for a quote-unquote strep throat. He recalls having had strep throat several times as a child, but was never treated. Now, I gave you some information here, and hopefully if you're looking at this right now, you're already starting to think about more information that you would want. And so what I would suggest at this moment is really to kind of either pause the video to write down or jot down some questions or thoughts that you might have about this, and write down a few differential diagnoses that you might think is going on here. Obviously, a big clue is that we're talking about cardiology, so something cardiac is probably going on here. But just sort of jot it down. When we discuss, we'll discuss this live, but I want you guys to think about it now as you watch the video. So when we discuss it over Zoom during the live lecture, we can kind of go into the more details on what's happening here. Okay, so now I want to begin with a very, very broad overview of the heart. Just talk about some of the gross anatomy and hopefully kind of jog some of your memory if it's been a while. So in terms of gross anatomy, yes, we need to know this anatomy again, right? We need to know about the left and right atria and left and right ventricles and their position relative to one another, right? So what we have is like the venous system draining into the right atrium, and it's colored in blue so that you can see that it's deoxygenated or lower oxygen content, and it's going to move that into the right ventricle. So allow me to draw this out here. So here we have systemic blood. Okay, so superior and inferior vena cava, and this is the right atrium, so it's emptying into the right atrium. One key understanding here is that the inferior and superior vena cava do not have traditional valves in the sense that we see valves over here, for example, right? That's an AV valve, which is otherwise known as the tricuspid valve, which separates the right atrium from the right ventricle. So we do not have those valves entering into the right atrium. Okay, and I'll come back to that in a minute. So we have the tricuspid valve goes into the right ventricle. From the right ventricle, we see there's another set of valves there. So this would be our pulmonic valve, and otherwise known as the semilunar valve. And then that enters into the pulmonary trunk, which divides into the left and right pulmonary arteries, heading out towards the lungs. Okay, and then from the lungs, oxygenated blood then returns via the pulmonary veins into the left atrium. Left atrium is separated from the left ventricle via another valve called the mitral valve. And then from the left ventricle, it's going to go into the aorta. And you see separating the left ventricle from the aorta is another semilunar valve known as the aortic valve. Now, I'm sort of reiterating this anatomy because it is so relevant to so many of the disease state, and the relevance really is in understanding how this is all they're all connected to each other serially, meaning that the right atrium goes to the right ventricle, to the left atrium, to the left ventricle, to the aorta, and so on. That they're all in series ultimately, right? So what that means is if I have a problem, let's say at the mitral valve over here, let's say it's stenotic, where it's a very tough valve, it doesn't really open, that can become very rigid. And if it doesn't open, that means the blood in the left atrium really can't get into the left ventricle. That could build up pressure and volume. And what happens is that reflects backwards because there's really no valve separating those pulmonary veins from the pulmonary vasculature. So that pressure could translate backwards in series, back towards the lungs. If the lung pressures then build up, that translates back to the right side of the heart. And if the right side of the heart pressures build up, that can translate back into the systemic circulation ultimately. Okay? And so that's when you might see something like extravasation of fluid in the lungs and edema, where they become short of breath, and then they have edema in the peripheral tissues and so on. So this is all because they're related in series, and it all may have happened, or in some cases, from something like the mitral valve becoming stenotic. And it might become stenotic for various reasons, which we'll discuss. Okay, so it's important to understand that serial relationship that they have with each other. The histological layers will also play a role. So we're talking about the endocardium, which is the innermost layer here, which you can kind of see in light pink here, okay, which I've kind of outlined there in the ventricles, but that's the endocardium, the innermost layer. The myocardium is the thickest layer, that's the muscle layer. And then you have the epicardium, which is the outermost layer. And so these will all might be differentially affected depending on the disease state. Blood flow, as I've already kind of reviewed for you, understanding its pattern of flow is very important. Also understanding its pattern of flow as well as the coronary blood flow, which is the blood flow to the heart itself. This is essentially how the heart, which is working non-stop, is going to get its nutrients. Okay, and remember the heart doesn't really rest. It rests for less than a fraction of a second. Okay, and it's going to contract like something like 4 billion times in the span of somebody's life. So this is constantly working, constantly needing energy, so it needs a constant blood flow. Later on in lectures, we're going to talk a little bit more extensively about this, but it needs a certain supply for the demand that it has. Okay, and if that supply is reduced, okay, it can become ischemic, right? So it doesn't have the nutrients that it needs to meet the demand. And so we'll talk all about sort of the ins and outs of those types of conditions. Another important point to make about that is that even under resting conditions, the heart actually will remove about 75% of the oxygen from the red blood cells. And that's under resting conditions, okay? Which doesn't leave it a whole lot of room. If you remember that deoxyhemoglobin curve, it doesn't leave a whole lot of room for it to extract more oxygen. So it really relies on blood flow to increase its oxygen. Pressure gradients, okay, which I have over here. Let me hide there for you. The pressure gradients. Again, blood is going to flow down its pressure gradient from high to low. And so that is sort of the basic physiology of what we talked about during the semester, but the basis of what I just talked about too, which is if we go from the right atrium to the right ventricle, the right ventricle, as it increases its pressure, well, that would actually move blood back to the right atrium, but it's prevented from doing so because we have these mechanical one-way valves which prevent that, right? If there's something wrong with the valve, that can actually move backwards because it'll go into the lower right atrial pressure system. If pressure in the right atrium goes up, it's going to go back into the venous system, which has very low pressure. So blood can move backwards under certain pathological conditions. And it's really heavily related to that pressure, those pressure gradients. The valves, of course, which I just mentioned an example for you though, but these are mechanical valves, okay? And we'll have a whole lecture on different disorders of the valves. And we'll also have a lecture on the electrical conduction of the heart, where we'll review some of the electrical pathways of the heart and talk about things like ECG as well. All right, so in terms of the modalities of evaluation, so we're talking about essentially our approach to the patient now, where we have our history, a physical exam, diagnostic test, and then hopefully we'll have a diagnosis. And that's essentially the general pattern with which we follow, right? We don't jump around. We don't get diagnostic tests typically first and then physical exam and so on. But there are some cases where we might skip around. The history, okay, is incredibly important, and there's a lot of telltale things that can give us an idea about the health of their cardiovascular system just from the history alone. And so we have to really take our time with the history. Now, that being said, we don't always have a lot of time. So again, I should preface this by saying that the history in context, right? If we're talking about ambulatory care, somebody's coming in for a well visit or something like that, we may have more time to be able to kind of get in depth with a patient and go through a more thorough examination. Other times, we're going to have a very concise, very directed exam because they might be coming into the ER, for example, with chest pain, and we need to kind of evaluate them more quickly. The physical exam, as you know, obviously at this point, it's going to be moving from the history and actually putting your hands on the patient, listening to the patients, auscultating them, palpating them, as well as observing them. And then the diagnostic tests, so we'll talk about a whole different type of diagnostic tests. Again, this lecture is really more of an introduction to those diagnostic tests, and you're going to see them popping up as we go to each individual lecture as it pertains to those particular diseases. And then, the diagnosis, I should really put there differential diagnosis. We may or may not come up with an exact diagnosis, but we should be definitely working on our differentials. Okay, so this list is just some of the diseases of the heart. It's not an exhaustive list by any means. This is just really kind of a brief introduction, and they're not ranked in any particular order, except that I will say that the top one here that I have in bold, the coronary artery disease, is by far the primary cause of mortality. It's also the number one killer in the U.S. here. In fact, it's found to be 1 in every 3 deaths is cardiac in nature, which may not be necessarily coronary artery disease per se, but it definitely plays a prominent role. So we'll be talking about lectures, a specific lecture for coronary artery disease, but then there's hypertension, which will have a lecture for that. Rheumatic heart disease, so this is the immune system mistakenly attacking our own tissue, which, that tissue could pertain to the heart, like for example, the valves. Bacterial endocarditis, so we talk about some sort of infectious etiology to the heart problem. Congenital heart disease, heart failure. There's an extensive list here. We also have certain arrhythmias, and they're not always mutually exclusive. In fact, some of these may be interconnected with other ones. So for example, you might have a patient with an extensive history of coronary artery disease due to atherosclerosis, and they may have had several myocardial infarctions or heart attacks in the past, and that may have led to a weakening of the heart, which is leading to heart failure. The heart failure, by extension, then can cause problems with the valves as the heart tries to adjust to the different pressures and so on, and it can cause valvular disorders. So these things can all become interconnected and so on, but we'll kind of discuss them as separate entities, but with the understanding that they can be connected. And hopefully we'll be able to appreciate that as we go. Okay, so signs and symptoms. So these are some of the ones to kind of look out for in terms of cardiovascular. But before I begin that, actually, we should understand that a symptom is what the patient relates to us. So we'll be clear on that. So the symptom means, for example, the patient comes in complaining of a headache, nausea, right? Feeling palpitations even. These could be symptoms that they're having. Signs are the things that we observe as healthcare workers. We observe what's happening with the patient. Okay, so we're actually measuring their blood pressure, right? Or we may have noted a rash or some edema. These may be signs that we have to note. So when it comes to the cardiac system, we have to understand that some of the most prominent ones, or ones that really should be triggered by when you're getting a history, are things like chest pain and discomfort. That hopefully seems like an obvious one. And then palpitations, which are essentially the sensation of feeling your heartbeat in your chest. Most of the times, with healthy individuals, we're really kind of unaware of it, except in extreme conditions, maybe when we're exerting ourselves too much or something of that nature. But this would be, them feeling their heartbeat, or at least aware of it. Dyspnea, which is shortness of breath, because it is linked serially within the structure of the heart, it's also can play a prominent role. Syncope. Syncope is a temporary loss of consciousness, right? Oftentimes due to something like a drop in their blood pressure. Fatigue. Fatigue is very broad, but when it comes to the cardiovascular system, understanding that the cardiovascular system is built in order to supply not only itself, but with the rest of the body with nutrients and oxygen that it needs to sustain activity, it would make sense that there's something wrong with the system that delivers this, that you would have fatigue of, not just essentially generally fatigue all over in the whole body. But then again, fatigue is not a very specific type of symptom. Edema would be swelling, right? And there's various types of edema. We'll talk about that. Hemoptysis, which is coughing up blood. You increase pressures in the lungs because the heart has backed up pressures, and you may rupture capillaries and so on, and that can lead to bleeding in the lungs. Cyanosis, which is the bluish tinge in the skin. So this is deoxygenated blood, and it may be because you have a poor vasculature in the lungs, an exchange there that's occurring. You may have shunting that's going on. We'll talk about different types of shunts in the lectures that come up. You may have poor peripheral vasculature. And so all of this could lead to what we call cyanosis, or sort of a blue tinge skin. Okay, so let's look at chest pain, which is really our primary complaint, one that should really raise a red flag for anything cardiac in nature. And keep in mind though, just because somebody has chest pain does not automatically make it cardiac in nature. However, that really should be at the top of our differential. But there are ways for us using the history and talking to the patient, and also with the exam, to kind of figure out what's really going on, whether this is cardiac in nature or not. So to that point, if you take a look at the box over here on the left, it says clinical characteristics of angina. Angina is referring to essentially chest pain. Okay, we'll talk more about angina in another lecture to come, but this is like an ischemic type sensation where the heart's in pain. And so if somebody comes in with chest pain, one of the things you might notice right off the bat is what you can see over here. Let me get my pen. Something called Levine's sign. Okay, there's a guy over here. You may not be able to see it, but he's clutching his chest, making a fist like that. And that's very characteristic of cardiac pain, where it's substernal crushing pressure, where they'll put the pressure right there, where it feels like there's almost like a belt around their chest or something sitting on their chest. And they'll usually refer to it as like a crushing type pain. That's very characteristic of cardiac. So you can see that type of pain is important, right? So dull pressure, that's more likely to be angina, versus something that is sharp and stabbing. Okay, sharp and stabbing is not typical. So for example, they may breathe in, and when they breathe in, they get a sharp pain. That's more of what we call like a pleuritic type pain, which is related to their breathing. Duration. We want to know about the duration of the pain. Is it last 2 to 5 minutes, or it's typical with anginal pain, it should be less than 15 to 20 minutes typically. Or is this seconds or hours? Seconds or hours is less likely to be angina. Again, it's not. It doesn't completely rule it out. It just means it's less likely. The onset, is it gradual versus rapid? Gradual is more anginal than rapid. The location is substernal, as I mentioned. But if they're pointing to like lateral chest wall or their back, it might be something else. Is it reproducible? So for example, do they get it when they exert themselves, right? Or is it when they breathe in, they have that sensation? Now, do they have other symptoms that go along with that, right? So do they have any kind of nausea, sweating, pain in their shoulder, pain in their jaw, or is that absent, right? And then when you examine them, if you put your hands on them and you feel around the chest, if you can reproduce the pain by feeling it, that's less likely to be cardiac. So for example, you push on their chest and they're saying, "Ow, that hurts," and that's saying that's where the pain is. Then it may not likely to be cardiac at that point. Because if it's cardiac, palpating the chest should not be painful. Now, what I want to give you guys here, something to use that you guys may be aware of already. If not, then it's called OPQRST. T. So you guys may be aware of this, and I think it's useful. So when you're getting a history of somebody who has chest pain, keep in mind OPQRST. So to kind of go through that, O stands for onset. Okay, so you want to know when the pain started. All right. So was this 15 minutes ago, 5 minutes ago? Was this seconds ago? Was this hours ago, days ago? You know, you want to get some of that information. That could be useful to you. P stands for palliation. So what makes it better? So when you stop and you rest, okay. The flip side to that is what makes it worse, right? So when I exert myself, you know, when I get stressed out or something like that. Q stands for quality. You want to know the quality of the pain. Is it dull, kind of a crushing pain? Or is it more of a sharp stabbing pain, or is it a ripping or tearing pain, and so on? So that can give us a lot of information in understanding what's going on. R stands for radiation. So you want to know where the pain is located first off, right? Is it substernal? Is it off to the side? Is it somewhere else, right? And then if it's substernal, let's say, where does it radiate anywhere? Do you feel pain anywhere else? Do I feel it in my left shoulder or my right shoulder? I feel it in my jaw, for example. Okay. And with R, all right, excuse me, with S, we want to know S stands for severity. So you can get a scale on 1 to 10, how severe is the pain. It's also good to ask at that point with the severity if the pain is stable or if it's getting worse. It's always good to kind of know where you stand with that, if it's getting worse or not. And then T stands for timing. So this is kind of a big question. The timing is, you know, kind of like onset, like when did it start? How long do these episodes last? Have you had episodes in the past? You know, so you want to know about the duration, the frequency of them. And so there's a lot of information that can be gleaned from that. T also stands for trigger. So anything that can kind of trigger it. Okay. All right. Now I've also put here, you know, angina pectoris, which again we'll talk about more in another lecture, but you know, some of the more common causes of it, aortic valvular diseases, coronary atherosclerosis, and we'll get into those details as we go. Okay, so palpitations. Palpitations is that sensation of your heart beating in your chest. And many things can cause that. So you could have a tachyarrhythmia where your heart's beating very fast, a bradyarrhythmia where it's very slow, escape beats, or beats we'll talk about more in the arrhythmia lecture. All right, but a PVC is a premature ventricular contraction, where you know maybe a muscle in the cardiac myocyte, excuse me, in the ventricle has decided to actually contract sooner than it was supposed to, and can cause a funny sensation in your chest, and we refer to those as a PVC. In fact, you can take a look at the ECGs over here to the right, and you can see these kind of funny looking waveforms. And we haven't really gone through this yet in detail in the ECG, but we will. And you can see some normal looking ones. You see the normal ones are right here. And then you see it followed by these kind of wonky looking waves there, these PVCs. You can see the same thing over here. They can cause the sensation of palpitations. And we'll get more into that in the ECG lecture. Other things that can cause that sensation, certain types of drugs and medications can do it. Alcohol has been known to do that. Smoking, the nicotine can interact with those autonomic receptors. Smoking, caffeine. Caffeine releases epinephrine, and so that can stimulate the heart to increase the rate. A thyroid, so an increase in thyroid, or if somebody's hyperthyroid, that can actually upregulate beta receptors on the heart and can act as a stimulant. And then, of course, panic attacks. Panic attacks are well known to cause things like palpitations and the sensation of chest pain and so on. Dyspnea, or shortness of breath. So again, this occurs because of the fact that the lungs are in series with the heart. So if the heart's backing up, it can back up into the lungs, and the lung is a very low resistance system, so it could be affected fairly easily in certain conditions. So I'll start with dyspnea on exertion down here. So the dyspnea on exertion, this is shortness of breath when they exert themselves. And this could be a sign of heart failure, which I've actually listed down here, a sign of heart failure. In fact, all three of these are signs of heart failure, where you have a weakened heart. Okay, it's unable to really effectively pump, right? And if it doesn't pump well, that means fluids can back up. If fluids back up, it can back up to the lungs and cause that shortness of breath. Now, it may be mild, moderate, or severe, right? And so in some cases, they may only feel it when they exert themselves. On the other hand, you may have something called orthopnea. Now, orthopnea is actually the sensation of shortness of breath when they recline or when they lay down. And so sometimes, especially with heart failure patients that have more moderate to severe heart failure, they're unable to actually lie completely flat, because what happens when you lie flat is you put the heart at the same level as the lower extremities there in the head. So everything's at the same level and there's no gravity to pull the blood from coming back to the heart. What ends up happening is, by reclining, blood return to the heart is increased, or venous return is increased to the heart. Now, if you already have a weak pump and you increase the amount of fluid it has to deal with, it may have difficulty with that fluid and it can back up and increase pressures, and that can cause shortness of breath. And so what you may find with orthopnea, the classic condition, is that they will actually use pillows, several pillows, to prop up their head to elevate it above the heart so that it feels like they can breathe again. And in fact, that's one way in which we can use a measure, more of an objective measure, to find out how they're progressing. So for example, they may have started out using 2 pillows and now they're using 4, right? So that gives us a relative idea of if it's progressing. The same thing actually with dyspnea on exertion. You can find out what their level of exertion was normally, right? They're used to walking, 5 or 6 blocks a day, and now they're down to walking, 2 or 3. That gives you more of an objective idea of its progression. Paroxysmal nocturnal dyspnea, or PND. So this actually occurs after the patient has fallen asleep, usually within about 2 hours or so. It's the same principle as orthopnea, where laying down causes an increase in blood returning to the heart. And in fact, that's what this cartoon over here is depicting. As you can see, there's an increase in venous return to the heart. That causes an increase in left atrial pressures in a weakened heart. That causes backup of blood into the lungs, and at around a certain point in the middle of the night, or I should say about 2 hours worth of sleep, it causes them to have extreme shortness of breath as the fluid is built up. So they can wake up in a panic, and classically they'll tell you they wake up very short of breath, gasping for air, and sometimes they'll run over to a window or something like that and open it up to try to catch their breath. And that could be associated with things like tachycardia, increased heart rate. If you were examining them, it could be crackles in their lungs, all right, from the fluid. They might be coughing and coughing up sputum. So things to kind of pay attention to, but these are sort of classic conditions of heart failure. Syncope. Syncope, as I said before, is a temporary loss of consciousness, and there are many causes for that. That could be both neurogenic, for example, if somebody had a seizure, versus say cardiogenic. So for example, if it's cardiac in nature, oftentimes they'll tell you that it was sudden in onset and that they recovered completely afterwards. They didn't feel confused or anything like that, which would be more of a sign of somebody who had a seizure. So some of the conditions for that: arrhythmias, certain conditions of the heart that cause arrhythmias. The arrhythmia can reduce their cardiac output, which would reduce perfusion to the brain and ultimately lead to loss of consciousness. Orthostatic hypotension. We'll discuss this more later, but this is essentially a drop in their blood pressure upon standing. So if they were reclining for a while and then they stand up, their blood pressure drops and that decreases perfusion to their brain. This can be a problem, particularly in the elderly. Vasovagal. Vasovagal is probably one of the most common causes of syncope. There are many things that can cause a vasovagal, but what's happening is essentially you have a drop in the sympathetic output and an increase in parasympathetic. So that's the parasympathetics will slow the heart down, and the vasovagal will actually cause a decrease in sympathetics, to the blood vessels, will cause it to dilate, and that decreases perfusing pressures to the brain and can cause somebody to pass out. And that's there are many stimuli for that. In fact, sometimes it's the sight of blood, for example, can cause that to occur, or a stressor, or another type of stressor. More rare would be the carotid sinus syncope. So just if you guys recall, the carotid sinus is a baroreceptor that's located at the bifurcation of the carotids at the angle of the jaw. So you can kind of see in the picture here, our guy here, he's pulling on his collar. This is less common, but you might see this sometimes in the elderly. Some people, if they have very sensitive baroreceptors, in the young, you might see it. And what can happen is, just a little bit of pressure on the baroreceptor there. Remember, a little pressure there causes the brain to think that there's an increase in blood pressure, so the output is to slow the heart rate down and vasodilate and so on, and so that would decrease the blood pressure. If it's very sensitive, there's just barely touching it, or if, in cases like this where there's the collar, this collar is high enough, if it's rubbing on that carotid sinus, it could actually inadvertently give the signal to slow the heart rate down and cause them to kind of pass out. Fatigue. Fatigue is very, very general. However, it is definitely seen in most of these cardiac patients. So it really kind of all depends on their cardiac output for the most part. So, if they have a decreased cardiac output in a lot of cardiac diseases, and that results in having, less blood flow per minute to the tissues that may have a higher demand, and it can lead to fatigue. But there are many, many causes of fatigue, which is why I've listed there's a large differential. You could have psychiatric causes for fatigue, okay? Thyroid disorders, right? So the hyper or hypothyroid, hematological disorders, if they're anemic or not, lung disorders because maybe there's not good gas exchange to the lungs, of course, cardiac disorders, and then things like cancers that use up a lot of energy in dividing so frequently. Dependent edema is something you can see in many cardiac cases, in particular in heart failure, for example, where if the heart is failing, again, it's not acting as a good pump, as blood is not being able to be efficiently moved or effectively moved through the heart, through the lungs, and into the system, it can back up. And if it backs up, particularly in the venous system, which doesn't have as high a resistance, and then again with gravity, it will help it to pool. So the dependent is really on the gravitational, the parts of the body that are affected by gravity. So oftentimes, with somebody, let's say, who has heart failure, you might see symmetric edema of their ankles, of their lower extremities, for example. There are other subcategories of edema. Sometimes we'll refer to them as effusions, and so these would not necessarily be in the dermis, but you might see things like ascites, right? So this is fluid in the abdomen. That could occur because, let's say, the person has heart failure, the fluid is backing up towards the liver, and then the liver gets congested, and that backs up even further and causes extravasation of fluid into the abdominal cavity there. Then you have pleural effusions, which is basically edema in the lungs, and then pericardial effusions. Now, in the picture here, you can see with these feet, all right, so you see the edema, and then you'll notice some of the dimpling there. So what you have right here is edema, what we call pitting edema. And so you can have pitting edema or non-pitting edema, and that actually gives us some diagnostic information. So just as an example, if somebody has pitting edema, oftentimes what happens is, you might see pitting edema in heart failure. So again, the fluid is extravasating into that extracellular space, and when you put pressure on it, as you put pressure on it, it kind of squeezes the fluid out of that extracellular space, sometimes into the lymphatics, and the lymphatics, which acts as like a vacuum for excess fluid, will just sort of suck up some of that extra fluid, and you can cause dimpling. On the other hand, if you have some sort of lymphedema or some blockage of the lymph, if you press on it, the fluid has nowhere to go, and so it may not pit at all. Hypothyroidism is another cause for non-pitting edema, but oftentimes with something like heart failure, you would see pitting. Hemoptysis, so this is blood in the sputum, and as you guys are going to see, when it comes to healthcare, we really don't discriminate when it comes to bodily fluids. We check everything. So you're going to be looking at sputum. You're going to want to look at the color of the sputum. You want to know if there's blood in it. Does it have clots? You're going to be looking at urine. You're going to look at stool samples, blood, you name it. Essentially, we examine everything because it gives us information. So hemoptysis, blood, if they're coughing up blood, we're going to want to take a look at that, right? We want to see if there's clots in it, if it's only kind of like lightly pink, if it's frothy, and so on. That's going to give us some clinical information. As you can see in the picture there, you can see a big blood clot there. Again, you might see this in a case, let's say somebody had mitral stenosis. So it's, a valve that's not opening really well. It's causing a backup of pressure, and that backup pressure could cause some of the vasculature, the smaller, more fragile vessels to rupture, and then the person coughs this up as a result. Cyanosis, again, it's that sort of bluish discoloration of the skin. And this really has to do with desaturation of red blood cells. And in fact, it's an absolute desaturation of hemoglobin. In other words, you will only see cyanosis if they had a very specific amount of their hemoglobin level that was desaturated, which is somewhere around 5 grams per deciliter. It's also broken up into peripheral versus central. Peripheral, the reason we break it up into peripheral versus central is there's different causes for each. So for example, in central cyanosis, it's telling us that there's something centrally causing the cyanosis, that bluish discoloration, the fact that they're desaturated, because you may have a shunt, let's say, a right to left shunt, where the right side of the heart has a hole, it speaks to the left side of the heart directly, so the blood moves from the right side of the heart directly into the left side, never going to the lungs, so it never gets oxygenated, and now you have deoxygenated blood mixing with oxygenated blood, and the person starts to look bluish. Okay, and that's called central cyanosis, and shunting is one of the major causes of that. There are others, of course. Peripheral cyanosis, this is not because of shunting or something more centrally located, but actually because maybe the vasculature is very poor. So typically you'll see it in like the fingertips, like the more distal areas, like the fingertips, the toes. You might see it on the tips of the nose or the lips, or underneath the tongue or the gums. These are all areas that have capillaries that come very close and are very small, like very close to the surface of the skin of the mucosa. And so you could see it more readily there. So you could look at, like, say, the fingernails, for example, and see a bluish discoloration of the fingernails. And so this is more peripheral. And so to help us kind of differentiate one from the other, at least on a physical, for example, peripheral is usually you can actually warm up the extremities, rub the hands or something like that. And if you warm them up, it would go away, because warming up the extremities causes vasodilation, increase in blood flow, which would cause that cyanosis to go away. If it's central, warming it up won't help any, okay? Because that's an exchange problem that's occurring with the lungs or the heart. Differential cyanosis. We're going to talk more about this in a later lecture, but that's actually what's pictured just beneath here. All right, this is differential cyanosis. What you'll notice here in the feet is that right here in the toes, underneath the nails, you see it's bluish, but if you look at the fingers, there's no cyanosis in the fingers. So there's a differential between the upper extremity and the lower extremity. And we'll talk more about why that is later on, but this cartoon over here is really depicting that. And just in brief, it has to do with something called the ductus arteriosus, which is a communication between the aorta and the pulmonary artery, which is normal during development, but if it stays open, it could actually be problematic and create this differential cyanosis. And again, I'll talk more to that in a later lecture. So coming back to the case, in terms of signs and symptoms, so remember, this is the case I started with on the second slide. The signs and symptoms for this patient, again, I want you guys to kind of work through this. This patient had shortness of breath, so they had dyspnea, okay? Mild chest pain, periodic palpitations, fatigue, and they had a cough with pink frothy sputum. So I want you guys to take that information, okay, in context of what you saw with the other slide, and come up with a lot more questions that you want to know about this particular case, okay? So moving on towards the physical exam. So on the physical exam, you want to inspect, palpate, and auscultate, right? That's essentially the order of operations, but not for everything, all right? Actually, in reality, as soon as you start to get a history from a patient, you're usually already inspecting them, all right? As we're actively listening, we should already be inspecting them. Their posture, how they're speaking, are they short of breath when they talk? Do they seem to be wincing? Are they leaning over? Are they favoring some side? Or they keep rubbing something? These are all things that we're gonna have to take notice of, right? Do they look like they have pallor, like their skin is very pale? Do they look cyanotic? So these are all things we will already typically be observing, but we need to make sure that we continue to do that during the physical exam. So for example, as sort of a general inspection, their general appearance, do they take care of themselves? How do they look? All right. Do they look more like they're panicked? Or are they hunched over? Are they having trouble breathing? Just general things to take note of, right? We're acting like a detective here. The temperature. And I don't mean just because, what's their temperature in terms of do they have a fever or not. I mean, feel their extremities, right? Feel them. Are they cold? Do they feel warm? If their hands, for example, are very cold, that could be because they have vasoconstriction or poor vasculature. Poor blood supply, which would be warm, right? So if it's cold, it may be because maybe some sort of atherosclerosis or constriction. Take a look at the hands. Their fingernails gives us a lot of information, right? If you take a look at that picture there, you can see in the picture, if you take a look at the fingernails here, there's these little splinters. So underneath the nails, that could be indicative of something like an endocarditis. So maybe this patient has a fever, okay? Maybe they have a high fever and you're seeing, particular signs like this. Might lead you to something like an endocarditis type differential. At the hands, you might see clubbing if, say, the person had chronic hypoxia. Maybe they have a lung disorder, or maybe they've been shunting for a very long time, and you might see this type of presentation where the tips of the fingers actually become enlarged, and we refer to that as clubbing. You can take a look at the face. The face may show a rash. It might look pallorous. You might see cyanosis. You might actually see a blue tinge in the sclera of their eyes, and that might tell you that's just a connective tissue disorder. And having a connective tissue disorder is something we need to note because that could reflect connective tissues in their heart as well, which would affect things like their valves, for example. We'll take a look at their chest. If we take a look at the chest, we want to know, just by examination, are there any scars there? Have they had previous heart surgeries? Do they have something called excavatum, which is, again, it's something you can see on a connective tissue disorder. Do I see increased, vasculature on their chests? In other words, there could be signs of collateral blood vessel perfusion going across the chest. I mean, like large veins across their chest because there's blockage of veins that are deep within the thorax there. In the abdomen, when you examine their abdomen, liver could be enlarged from backup of fluids from heart failure, right? So you can palpate a very large liver. You might feel a palpable pulsating mass like an abdominal aortic aneurysm. You could also feel an enlarged spleen in something like an endocarditis. So we have to make sure we examine the abdomen. Pulses. You want to examine their pulses. Remember the pulses, radial pulses and femoral pulses, right? Carotid pulses and so on. You want to get an idea because the pattern of the pulses gives you a lot of information about just, for example, the rhythm of the hearts. And then jugular venous pressure. You want to take a look at the jugular veins. Do they have any kind of distension, right? You can see over here in the last picture there, something called a xanthoma. You can see that on the skin, which is, on the joints in some patients, where they might have some sort of familial type disorder where they have high cholesterol levels, and that can actually represent itself on the body as these sort of raised lesions, or called xanthomas, which would, kind of moving past that, we would say, well, if they have xanthomas and high cholesterol, they might have a higher likelihood of atherosclerosis and coronary artery disease, right? So this is, again, further general inspection, right? So here you can see excavatum in the chest, so connective tissue disorder, which is common with something, let's say, Marfan syndrome, which causes problems with valves, causes problems in the aorta. You can see down here a scar, all right, an incision there, maybe from an open heart surgery, which we'd have to question them about, right? Over here, you can see jugular venous distension. Again, you might see that distension because there's increased pressure in the right atrium, and there's no valve separating the jugular veins from the right atrium, so any pressure that builds up in the right atrium would translate backwards into the veins there. When you take the blood pressure, again, we're going to have a different lecture on blood pressure, but, we would take a look at a pulse pressure, which is the difference between the systolic and the diastolic. That gives us information. So, for example, you might have, a very wide pulse pressure in somebody who has aortic regurgitation, okay, or what we call aortic insufficiency. On the other hand, you might have a narrow pulse pressure in somebody who has cardiac tamponade. And these are conditions that we'll discuss. And that gives us, again, it helps us kind of flesh out our differential. Orthostatic hypotension, which we've discussed earlier. Okay, drop in blood pressure as they're standing. Supravalvular aortic stenosis just means there's stenosis above the aortic valve. It's not the valve that's stenotic, it's the aorta that's stenotic just above it. And that can actually cause differences in blood pressure in one arm versus the other, for example. Coarctation of the aorta, which means a constriction somewhere along the aorta. So in the cartoon over here, you can see this constriction right there, which can actually happen before or after the ductus arteriosus. So we call it preductal or postductal. But the main point I want to make here is that by causing, if there's a constriction in the aorta, remember the constriction usually happens after the arch, which means, if you recall, these branches on the arch here actually feed the upper extremities. Okay? It needs to traverse down the descending portion of the aorta to reach the lower extremities. So if I have a stricture there, that could increase blood pressure in my upper extremities by diverting more blood to those areas, and there's less flow to the lower extremities, so I might have lower blood pressure there. And so I could have a change in the blood pressure from my upper extremity to my lower extremities. And again, we'll talk more to that in another lecture. Cardiac tamponade can cause something called pulsus paradoxus, which is a changing in your blood pressure when you breathe. Palpation, again, you're putting your hands on the patient. So when you put it on the precordial or on the anterior chest wall, you're feeling for something called an apex, or the PMI. So remember, the apex of the heart should be towards the left, right? And standardly, the normal apex is located at the midclavicular line in the 5th intercostal space. Okay, that's more standard. You know, but if it's shifted to the left, that could signify something like an enlarged heart, for example. Heaves. You could actually feel the heart beating and pushing up on the sternum or the chest. Typically to the left of the sternum, you can feel sort of a raising of the chest wall. And that could be indicative of an increased right ventricular hypertrophy or an enlarged right ventricle, especially since the way the heart's positioned, the right ventricle is close to the anterior chest wall there. Thrills would be, you know, feeling a vibration. Sometimes it's referred to as like a cat purring. You can feel that. That vibration could be coming from turbulent flow in the heart. So that could tell you about a valvular disorder. The pulses, as I've kind of already alluded to already, by feeling the pulses, you know, you feel rates, rhythm, and the strength. I mean, somebody who has atrial fibrillation, for example, may have a very irregular pulse. Just feels like it's all over the place. So sometimes you can gauge some rhythms just from the pulse. You may have very strong bounding pulses with a sudden drop. Okay. Other times you might have someone who has very weak pulses, or you can't feel a pulse at all, and that may be reflective of a drop in, of vascular disease. And so we'll get more into that as we go. When you get to the auscultation part, now we're actually listening to the chest, right? We're not just listening to heart sounds. We do listen to the lungs as well, because again, they're linked serially. So if there's a problem with the heart, if it's backed up, that could back up into the lungs, and you might hear things like crackling and so on, or fluid in the lungs. So I'm going to have a whole separate lecture for different heart sounds, so I'm not going to spend too much time on this. But understand you have 4 valves, right? The ones we discussed. You can hear those. That gives us our S1 and our S2, that lubbed up sound. All right. You listen to those lung bases versus the apex. You're going to listen to the carotids for any kind of bruits, which is really just, you know, turbulent flow in the carotids that signifies something like atherosclerosis. And then we're going to talk about dynamic auscultation maneuvers, where you have the patient hold their breath, breathe out, you know, turn to their side, stand up, and so on, so that we can kind of manipulate the sounds a little bit to get a better understanding of what's happening. And then you'll see that those little points over there, the aortic, pulmonic, tricuspid, and mitral areas on the chest, those are just designating areas that are best to hear those particular valves, but you can actually hear all the valves from any of those spaces. It's just they're more amplified in those particular areas. And then Erb's point is actually, you know, a good area to listen to both the aortic and pulmonic sounds. Again, for those heart sounds, we're going to get more detail, but we'll discuss S1s and S2s, what an opening snap is when it comes to the AV valves, ejection clicks for the aortic valve, for example. You know, murmurs, which is turbulent blood flow, what rubs mean. So they have the, you know, the pericardium that surrounds the heart, can kind of create friction, which creates like a sandpaper sound, which creates a rub. And then there's gallops, which are these extra sounds, S3 or S4, which can be indicative of certain types of heart failure. So kind of coming back to our case here, on the physical exam, all right, you want to make sure, for our patient, on inspection, all right, we had pinkish purplish patches on the cheeks, which you can see actually in the cartoon over here, or not the cartoon, excuse me, on our patient over here. You can actually also see some cyanosis on the lips and there on the nose as well, maybe some on the ears. So he's cyanotic. He's got those pinkish purplish patches, and he was noted to have strong pulses in his neck veins. His arterial pulses were diminished, but there was a normal rate and rhythm that were noted. On palpation, he had a precordial heave, okay? A parasternal lift was noted, so you can feel a little bit of lift. On auscultation, the lungs, there were rails, so there was some crackling at the bases, and there was a diastolic murmur. All right, so here you guys can kind of challenge yourselves a little bit when it comes to heart sounds. All right, we will, again, I'll have a lecture on this, but you can challenge yourself. There was a diastolic murmur. So what was heard was an opening snap that was best heard at the apex of the heart. So that's going to help us localization there. Okay, so I want you guys to try that out, put that in context of everything we've talked about in that case so far. All right, because we'll discuss that more in person. Okay. Okay, so now what I'd like to do is talk a bit about some of the diagnostic tests, just to give you an overview. As I move forward and talk specifically about certain cardiac diseases, I will be mentioning some of these tests. So it's kind of good to have at least a brief overview of how some of these work and what we're really looking at. ECG I'm going to spend very little time on, simply because I have a whole series of lectures designated to ECG specifically. But to that point, we'll learn about how to assess somebody's rate rhythm, what an axis means, what the intervals are, how to assess for ischemia or hypertrophy, if there's any kind of conduction blocks, or something we refer to as a pre-excitation. So we'll get more into that later. But before I kind of move on to talk about this chest X-ray, the ECG is used as one of essentially the gold standard for so many different assessments. And it can be done before the patient even reaches the hospital, as some of you may already know. And so it gives us a lot of information, especially if you have your classic chest pain patient. Part of the workup for the chest pain is going to be an ECG, and the ECG is going to give us the information we need to be able to make some of the clinical decisions that we need to make. Chest X-ray. So chest X-ray is another one of the standard tests that's going to be used. One of the important things to understand about the chest X-ray in particular is that we need to understand what's really showing us. Ultimately, with an X-ray, the X-ray is showing differences in density of a tissue. Okay, so for example, when you see here in the chest X-ray, we're looking at a frontal X-ray. And you can see the lungs, and you look at the heart. So let me get my pen here. All right. So over here, you can see the lungs are kind of darkish. All right. There's not a lot of tissue there. It's mostly air spaces. It's not very dense. And so the X-rays tend to pass right through there and hit the film on the other side of the patient. So less dense would show up as darker areas. And so if we have areas that have like a lot of air in them, like the lungs, for example, they'd be very low density. They would generally show up as darker structures. The more dense structures would show up brighter or like white. And so you can see a lot of the bones, for example, a lot of the the ribs over here. You can see some of the part of the scapula, the clavicle. Okay, but here even the outline of the heart. You see the outline of the heart is contrasted nicely against the lungs there. The heart itself is, a much denser tissue than is the lungs. But what you'll also notice with that is that if I look just at the heart, it really just kind of looks like essentially a white blob, if you will, with a particular shape. The shape for us is actually what we're really looking at. It's very, very important, is that shape. And I'm going to kind of show you more on that in a little bit. But so one thing we can take a look at is the shape. The reason I can't tell much else is because really the valves, the blood that's going through the hearts, and the tissues of the heart are all of about a similar density. So it shows up essentially like one big mass. And that's because really all the architecture in the heart is approximately the same density. Then you can see the diaphragm right over here. Okay. And you see how kind of whitish that looks too, because it's, it's a higher density, especially if we're looking at the lungs. You may have also noticed this structure over here. All right, it's kind of blackish. It's a little less dense. It's an air-filled structure known as the trachea. So you can actually see the trachea there, which is more central. And then you can see it kind of bifurcates where I drew it down here. There's bifurcation of the carina right there, where it's going to bifurcate into each one of the lungs. And we can see that as a less dense structure because it's air-filled. So now let's take a look over here to the right. We need to remember our anatomy when we're reviewing the X-ray, and again, keeping in mind that it's really comparing densities. So if I have two structures that are next to each other and they're of similar density, it will look like essentially one structure on an X-ray. So in order for me to be able to really tell one structure from another, they have to have some separation of density. Okay. So here, you can see the lungs, which are drawn out for you. You can see the lobes will be a little more difficult to pick out, but you can actually see the lobes very clearly in certain pathological conditions. So it's drawn out and kind of labeled some of the areas for you, so you can kind of see it a little bit more clearly. But on the left side of the heart here, so this left border, okay, the left border on the X-ray is the left ventricle, and you can see the apex down here. So we have the left border, and then over here, a little blip over here, that's the left atrium. All right, so more superior to the left border there, that'd be the left atrium. And then you know that the left main bronchus would go out to each side of the lung over here. You have another bronchus over there going to the right lung. And so we can see a kind of a little density over there. Okay. You might also be able to see a little bulge above that, which is the part of the aortic arch, actually. So the aorta, again, as it's coming around, it's going to make this arch. Here you can see the branches to the aorta right there. And then this surface of the heart over here, that's really the right atrium based on the way it sits. Then you have the inferior surface, which sits along the diaphragm, which is really mostly the left ventricle with some of the right ventricle as well. Okay, the apex is actually the left ventricle under normal circumstances, and so the left border, the apex, and most of what's sitting on the diaphragm is actually left ventricle. And so a lot of the left ventricle we can't even see because it's, we don't see the border of it because it's actually a posterior structure. We can only see a small little bit of the left atrium because the left atrium actually faces more posteriorly. It faces more towards the esophagus, which is running behind the heart. So you can see over here, here's some of the structures again. Over here, you see the right atrium. Here's the left ventricle. Here's the apex down here. This is the part that's sitting on the diaphragm, which is mostly left ventricle, but could be some right ventricle as well. And then you got a little bit of a bump right there, which is probably the right atrium right there. Okay, so knowing the borders of the heart is important. Okay, we need to understand what those borders are. So if we see some sort of abnormality, we'll be able to relate it back to what that structure actually is. So for example, on the right border of the heart, okay, if this bulges out even more over here, we might have right atrial hypertrophy or an increase in the volume there. Or we could have a bulging over here, which would be correlating with the left atrium. And so we'd say, all right, well, if we see an enlarged left atrium on the X-ray, I can only it only helps me with my differential. It doesn't make the diagnosis. But for example, this person might have mitral stenosis, right? And so the left atrium has a lot of pressure, and so it becomes larger and it holds on to more volume. You might be able to see that on a chest X-ray. Or let's say they're in heart failure and the left ventricle is enlarged. You might see the apex of the heart moves all the way more laterally. So it just looks like a much larger silhouette. And so that we can say maybe that's an enlarged heart, right? Something else you guys might see in the clinic is oftentimes they'll talk about the frontal X-rays as being posterior to anterior X-rays. What that really just means is the orientation with which the X-ray is being shot through the thorax. So when they say posterior to anterior, it means the X-ray is shooting from the posterior side of the patient and going towards the anterior to the film on the anterior side of the patient. So the X-rays are coming from the posterior and landing on the anterior. And really, the only reason I have to specify this is that most commonly they're posterior to anterior, or what they call PA film. And this has to do with the silhouette of the heart itself. So what you could imagine for a second is, let's say that I have a flashlight, okay? And that flashlight, let's say, is actually my X-ray machine, right? So I'll shoot the X-rays out. So we have a light beam instead. And let's say I take my hand. And I take my hand, if I move it closer to the light source, what happens is, as the light hits that, it creates a shadow on the wall behind it. The shadow on the wall, the closer I move my hand to the flashlight, the more distorted the shadow becomes and the larger the silhouette of my hand looks. However, if I take my hand and I move it away from the flashlight and move it closer to the wall, the less distorted my hand looks and the more it represents the actual size of my hand. It's the same thing with the X-ray, actually. The heart sits more in the anterior part of your chest, so I'm going to shoot the X-rays on the posterior side, which is further away. I'm going to create more distance between the heart and the X-ray so that when it hits the film, it doesn't distort the image of it like the shadow. So I get one that's more representative of the actual heart size. That's an important feature when you're assessing somebody's cardiac silhouette size if you're going to diagnose something like hypertrophy, for example, or an enlarged heart. With that in mind, you could also assume that if I had a very thin patient who has a very narrow thorax, that an X-ray might make their heart look larger for the same reason. Okay, so we have to keep that in mind. Oftentimes we'll pair a frontal X-ray with something called a lateral X-ray, which is looking at the side view. And there, what they'll do is they'll use the X-ray machine on the right side of the thorax and aim it to the film on the left side, because remember, the heart actually faces towards the left, or it leans more towards the left side. So that way it helps with the distortion problem as well. And just before I move on here, you can see some of the veins again. You have the left pulmonary artery over here. You'll notice this little notch right here, which is an important one to keep an eye on. That's the aortic arch. And in fact, you can kind of follow it a little bit here, or you can kind of follow the pattern of that arch right there. The innominate is the brachiocephalic vein on either side. You can kind of see an outline of the superior vena cava over here, and down here actually would be where the inferior vena cava is entering into the right atrium. So those would be other important structures to kind of pay attention to. So again, like I said, we can take a look at the size of the heart. So the X-ray helps us with that, right? So we can see if there's enlargement. So in order to do that, we take a look at what we call the thoracic diameter. And we want to know if the heart is greater than 50% of the thoracic diameter. Now, this is with understanding that generally when we have somebody take an X-ray, they're breathing in, okay? Because if they're breathing out and exhaling, the diaphragm is higher and the heart kind of sits more sideways, and it can make the heart look a little bit wider. So we measure the width of the heart, which you can see there in orange, and we make a ratio of that to the inner thoracic diameter. And if it's less than 50%, not enlarged. If it's greater than 50%, that would be considered abnormal. We would assess the shape based on the outline there, and then of course look at the surrounding tissue. We take a look at the lungs. Does the lungs look congested? The more congested the lungs look, meaning there's more fluid in the lungs, the denser they appear, or the whiter it appears on a film. And so we can see increases in density, increases in vasculature as it kind of gets more congested, so you can see more of the vessels than you would normally be able to see. So this can all be telltale signs of things that are going on with the heart as well. So here in these images here, you can see again the frontal view giving us the ratio. So down here is a normal right here, and this would be a very enlarged heart, as you can kind of clearly see there. This would be a lateral view. You can see the outline of the heart right here. Okay, as you can see, it's more anterior in the chest, and typically this is a lateral view, but if it were the frontal view, the X-ray would be back here and the film would be right here. Okay. And so you can see that gives us more information again in assessing the lungs and any kind of densities in the lungs and other parts of the lobes of the lung, but also gives us a little bit more image of the heart itself, so we can see more of the posterior structures as well, like the left ventricle, as well as more of the left atrium, which most of it sits posteriorly there. And so before I move on to echo, again with the chest X-ray, if somebody had, say, heart failure, you might see an enlarged heart. And if they have very severe heart failure, if its pressure is backing up into the lungs, you could see an increase in vasculature in those lungs, for example, and you might see congestion and fluid that builds up at the bases there would show up as more of an increase in density in the lungs. And so that kind of picture can kind of be put together. But understand, there could be other reasons for having an enlarged heart that may not have to do with hypertrophy or heart failure, for example. You could have somebody who has some tamponade there, or blood that's gotten into the space around the heart, which can cause it to look, enlarged. So these are things that we'll kind of keep an eye on. It could also be the fact that the person has a very thin diameter of their chest wall, and their heart looks enlarged by comparison. Okay, so in echocardiography, this is another one that's very widely used, and the great thing about echo is that it doesn't submit us to any radiation like an X-ray would, and this device is relatively cheap, and it can be done at the bedside as well. So they can be taken to a room specifically for this, or they can do it at the bedside, which is actually very helpful in a hospital because the echo can make many different assessments, and really the usage of it or how much we can get from it can also depend on how good the person is at using the echo itself. Now, that being said, there are several types. We have what we call the transthoracic echo, which is classically what we think of, which is essentially you have the transducer, and the transducer usually puts some gel on that, and then it's put on the chest, and it's put in certain areas of the chest to look at the different anatomy in the heart as it sits in the chest, right? So we'll go in those different intercostal spaces, and we might take the transducer and turn it 90 degrees to get a longitudinal look or a cross-sectional look of the heart. So depending on how we position the transducer and where we put it, we're going to look at different structures either longitudinally or in a cross-sectional manner. So the TTE is the one that's actually done through on the chest. The TEE, or the transesophageal, is actually a smaller device that's actually slipped into the mouth and down the esophagus, and can actually look at the posterior aspects of the heart a little bit more clearly. So you can see that over here in the top cartoon there. And it's really very useful and actually much more sensitive for things like that are going on in, say, the left atrium. So if somebody has a replacement of a valve or a thrombus that's in the left atrium, we can see that more clearly with the TEE. We also might be able to see other things a little bit more clearly in the left ventricle, for example, because some parts of it are more posterior facing. It's also better for looking at things like the aorta, since it's in close proximity to the aorta as well. And it also doesn't have as much tissue to attenuate the signal, so it could be a preferable, albeit more invasive type strategy. So it's typically not the one that's employed more often. It's typically the TTE that's used more often. In addition to using these ultrasound waves, we can use them in different ways, because what's happening is we're basically getting reflection of sound back to the transducer, and they can give us some information about sort of relationships of the anatomy in a two-dimensional feature. They do have one-dimensional, something referred to as an M mode. There's a 2D, which is the most common, and then you also have 3D, which can give you a 3D rendering image, which is actually pretty neat. But using this this ultrasound, we can also perform what we call a Doppler, right? So we can actually calculate how fast something's moving. We can calculate velocities of blood moving through the chambers of the heart or in the aorta, for example. And so we can get that using a Doppler image. And you can actually code the Doppler images with color, so you can see the directionality of where the blood is flowing. And that's super useful in the heart, because not only can I measure velocities and so on in the heart, that actually helps me to calculate different areas of the heart, so areas of the valves, so I can figure out if a valve is stenotic or not by calculating the velocity of the flow going through it. Something would have a higher velocity if it were a narrower area, and it'd be a slower velocity with a wider area, for example. And then you can color code that, which is really great, because you can see the blue and the red imaging down there, which is showing you some Doppler. And that can actually give me directionality and also visually show me if I have backflow of blood going through one of the valves. So I can tell if I have any kind of insufficiency or a stenosis or something of that nature. And you can also use contrast in certain cases as well. Many cases don't require contrast, but you could use contrast, and that'll actually help again to kind of highlight certain areas of the heart and give you a little bit more about the architecture. Um, but I do know it's also been used for something called a bubble study, which is essentially you inject a contrast into the veins very rapidly as you're using the ultrasound. You can see the contrast enter into the right side of the heart, and then it should, under normal circumstances, go into the lungs, where it's basically harmlessly taken away into the lungs and doesn't return to the left side of the heart at all. So you would never see the contrast enter into the left atrium or the left ventricle, for example. However, if, let's say, somebody has communication between the right atrium and the left atrium, for example, when you add the contrast, it might actually move across from the right atrium to the left atrium, and then you can see the contrast light up the left atrium as well. And so, we can actually glean some information about, say, something that might be causing a shunt, for example. Now, often with these echoes, what we're really doing is the way we're evaluating, or what we're evaluating, is chamber size. So we want to know if the chamber has been enlarged, or if it's even gotten smaller. We can take a look at the wall thickness to see if it's actually hypertrophied, and we see a thicker wall. Wall motion abnormalities. So see if the wall is moving every time it contracts. Because remember, the heart's moving this whole time. You can take a look and see if it's moving uniformly and if it's moving normally, or if there's a portion of the wall that's not moving normally or contracting abnormally, which might be an indication of poor coronary blood flow to that portion of the heart, because maybe the person has stenotic coronary vessels, for example. So it can help us to locate the area of the heart that's affected. Valvular function, as I kind of alluded to that already, with measuring blood flow through there to measure the area of it. We could also measure blood flow directly, and again, that could give us calculation for cardiac output. Something called an ejection fraction. So just as a reminder, the ejection fraction, that is the stroke volume divided by the end diastolic volume. And so that gives us an ejection fraction, which in normal is right around 50 or 60%. And so that's actually one of the measures that we use to evaluate left-sided heart function. So it's something that the echo can do very well. And then other measurements that we can make and figure out the hemodynamics within the heart there. But again, it's essentially replaced a lot of some of these other modalities that are more invasive, and because this is less costly and less invasive. So here it's showing you again the echo. You can see it on the chest wall here, showing the transducer held in different positions. This is something you guys will get to kind of learn as you go. You may have a course on that, where it's held in this position and it can be turned 90 degrees. Now, depending here, we have what we call a parasternal short axis. So the transducer held in this position gives you a parasternal short axis. Now, again, depending on where I'm holding it on the chest, I'm going to see different structures of the heart, right? So you can see the left ventricle right here. And the left ventricle, generally in a short axis view, which is like a cross-section view, looks like a circle. And then the right ventricle, which is smaller, tends to have kind of a half moon shape right here. That's very characteristic. So the transducer, again, if we're looking at it here, the transducer would be right here on the chest wall, and it's sending out a beam that goes wide like that. And so the right ventricle, as you know, is closer to the anterior chest wall, so it would be closer to the transducer. And then the left ventricle, which is more posterior structure, is behind it. And you see, again, that would be more patent or more rounded. The parasternal long axis view. So now I just take the transducer into the same position. All I have to do is turn it 90 degrees. And again, here's where the transducer is, okay? And then this can actually give me a better view. So here's the right ventricle, which is right up here, just close to the anterior chest wall. Right behind it is the the left ventricle. You can actually see the aortic valve right here. You can see some of the left atrium. And again, this is actually part of all of this right here. Sorry, this is all really sloppy. I want to fill it in though, but this is all left ventricle. And so it actually gives us a nice view of the left ventricle, left atrium, as well as the valves. So these different different positions give us different views. And then again, you can take that transducer and move it to a different position on the chest and repeat the same procedure and get different views. And again, it's doing this dynamically while the heart's moving, and you can see the walls moving. You can measure the thickness. You can measure the openings to the valves, get a cardiac output, get an ejection fraction, so on. You can measure. You can take a look at things like vegetations, which are if there's anything seeding the valves, like bacteria growing on the valves, for example. We would also use this maybe during a stress test to see how the heart has reacted to exercise. Okay, so there's different things, different assessments we can make with this. So it's become a very, very useful tool, and you'll see that we use it for a lot of the cardiac conditions I'm going to talk about, most, if not all. So here, here in the echo here, what you're seeing again, here's where the transducer would be. It's labeled it for you. You can see there's the right atrium. Here's the left ventricle, left atrium, just to give you kind of a position. What you're seeing here, this darker space, and again, the darker space, this is an area that would be filled with fluid. So this is actually the outline of the heart here. You'll notice it's kind of compressed, and there's actually fluid here that's compressing it, and this is the pericardium up here. So this is a pericardial effusion, excuse me, that's actually putting pressure on the heart and causing it to compress. Over here, you can see the bubble study that I mentioned before, which is where you actually inject contrast intravenously. And you can actually see the contrast over here on the right side of the heart. And here is an opening in the wall of the heart. So this person actually has a communication between the left side of the heart and the right side of the heart. And you can see some of that spilling into the left side of the heart there. Normally, you shouldn't see any of that contrast in the left side of the heart. In fact, over here, if you see a still of it, here's the right atrium, this area here is the left atrium, all right? And so this would be the interatrial septum, and there's an opening in the interatrial septum. So when the dye goes into the right side of the heart, normally the dye will just get into the lungs, it won't go past the lungs. But in this case, it gets over to the left atrium through an opening. So we have a communication between those two. So the stress test. Stress test, this can be, done either via an exercise, using a treadmill or a bicycle, or sometimes they'll use one of these arm machines to kind of, basically the idea is to increase the sympathetic output, to increase heart rate, to induce some of the chest pain. So why would we do this to a patient? So if a patient comes in and they complain of having episodes of anginal pain or chest pain, and we have good suspicion that this is cardiac in nature, but then you take, let's say, an ECG, and the ECG does not show any changes that would suggest, some sort of ischemia or anything. It could look normal, because oftentimes the patients with chest pain, let's say they come in, they're not in chest pain anymore, their ECG could have returned to normal. It may look completely normal. In which case, we want to know, was that an ischemic event or not? And so one of the standard ways to do that is to, schedule them to come in for a stress test, hook them up to an ECG, and then monitor and get them to actually increase their heart rate, to exert themselves, to see if you can reproduce the pain that they felt, to see if that causes any changes on the ECG and if they're significant or not, right? To see if there's any other hemodynamic changes. Maybe their blood pressure changed because their heart's failing, so we monitor their blood pressure, for example. And so it gives us a chance to see. So as soon as somebody starts to show those signs, we can stop the test and evaluate and see if in fact this was cardiac in nature or something that warrants further examination. So it's a worthwhile test to do. Now they can exercise or they can do something pharmacologic. So for example, in some cases, some patients are not going to be able to do any kind of exercise, maybe because of their body habitus. They may, have an amputation, for example, or something else that precludes them from being able to exercise. And so you can do it pharmacologically by using something like dobutamine, which would stimulate the sympathetic nervous system, similar to exercising. Or you can use something called adenosine. Adenosine is actually, more preferred. And what's interesting about adenosine is adenosine, which is actually a breakdown product from ATP. All right, adenosine causes vasodilation of the coronaries. And if, let's say, somebody has a constriction of the coronaries somewhere, all right, if you add adenosine, Adenosine is going to cause vasodilation everywhere except at the stricture. And so what ends up happening is it shunts blood flow to those areas that are now vasodilated and away from the area that's constricted, thereby actually reducing flow through that constricted area even more so. So it causes that ischemia. And so they call that a steal, coronary steal syndrome, where essentially by vasodilating everything else, you cause flow to increase everywhere else except at the constricted area, which didn't respond to the adenosine. So what we call standard stress testing is going to use an ECG, but echo can also be used. Echo is typically going to be used more often in patients who have an ECG that at baseline is not very good. It may have some other complicating factors, like they may have something called a left bundle branch block. They might have a Wolff-Parkinson-White or something of this nature that would, which would, inhibit their ability to make a good assessment. So we might prefer then to do an echo, for example. But you could also do, positron emission tomography, which is a PET scan, which uses radioisotopes, and this can evaluate the heart. It's very sensitive, very specific, but they can be more invasive, and they're also a lot more expensive, so that's usually not preferred. Some of the indications to get a stress test I've kind of already mentioned. It's basically to evaluate coronary artery disease for the most part, but they may have shortness of breath, which you think is cardiac in nature. If you think the person may have some pulmonary hypertension or valvular disease, these are, a stress test could help you to evaluate that. Some contraindications to a stress test, of course, though, for example, you wouldn't give dobutamine to somebody who has tachyarrhythmias and systemic hypertension because it could definitely worsen that. In terms of exercise, if they're having an acute MI, they have unstable angina currently, they're decompensated heart failure, dissection, pulmonary embolisms, these are, this would definitely exclude them from getting an exercise stress test. I mean, it should seem obvious that if somebody's coming in acutely with chest pain into your ER, you're not going to be putting them on a treadmill, essentially. Or if they're in your office and start to have chest pain and they're having an acute MI, then you're not going to be stressing. You're not going to be stress testing them, right? Physical disability, that would prevent them from doing an exercise, but then we could do something pharmacological. That would help us to kind of figure out what's going on there. In terms of nuclear imaging, so nuclear imaging is great. So this is actually uses something called a gamma camera, and so these specialized gamma cameras can pick up some of these radionuclides that we can use. So these are tagged elements like thallium or technetium-99, and these would be injected, and they're radio tracers that these gamma cameras can pick up, and they have specific properties that make them useful in evaluating patients that have heart disease, particularly coronary artery disease. So it can help us assess myocardial perfusion. So since the heart really relies on perfusion, what happens is we could actually inject something, say like thallium-201. If I inject thallium is like a potassium analog. So it acts just like potassium. It gets into cells just like potassium. In fact, it can use the sodium-potassium pump to get into cells. And it can redistribute at will. Okay? So it gets into these cells. As long as the cells are alive, it'll get in there because it can get in because of those pumps. So what happens is if you inject thallium, it's going to light up all those living cells. And you can see that on the camera. And in fact, you can see it in the image here, which you're looking at over here. All right. This all is lit up area right here. This circle that I just outlined for you, that's actually the circle of the ventricle. Remember I mentioned that on the earlier slide. That's the ventricle. And there's like a moon shape or crescent shape. That would be more the right ventricle. So we're looking at a cross section of the ventricles here in this image. So it kind of gives us a donut shape for the ventricle because we're looking at it from a cross section. And so you see how it's all lit up there. All right, this highlighted what kind of looks like a yellowish orange color is lighting up and it's filling up. So you can see it's marked at rest and during stress. So when you inject it during rest and you look at the heart, you see that it's distributing through all the tissue. So it looks like all the tissue is alive. It's taking up the thallium. And then when they exercise, during the stress, you'll notice that there's an area here, which we sometimes refer to as a cold spot. And you see it's not filling up as well because as it gets stressed and it becomes occluded, or it's an occluded area, it doesn't have as good a blood flow. So blood flow increases to those other areas and maintains it, but it can't really increase to the area that's demanding it here. And so it shows up as a cold spot due to poor perfusion of that area. And so it doesn't get to those cells as readily. So normally the order of operations is this. They exercise, and then after the exercise, you've injected it, you take a look quickly right after their exercise, and you would see the stress first. And you see if there's any cold spots like you see there, where it's not filling up adequately. And then you give it a few hours, and you re-image them. And during those few hours, the thallium has had a chance to kind of go in and out of cells and redistribute a little bit. So as they've rested and the perfusion to the area has improved, you can see that the cold area essentially went away. So it's an ischemic area. So it helps us to see the area of the heart that's been affected, maybe the coronary distribution. Very useful information can be taken from this. Now at the same time, maybe the result would be a cold area that did not recover after rest. It stayed cold. That might indicate that there's dead tissue there, right? Why would that matter? Why would I want to know if it's dead tissue versus still living tissue? Well, I might want to revascularize or open up a coronary artery if I know that there's living tissue that I can rescue. But if the tissue is already dead and it's dead at rest, then revascularization is not going to help that tissue any. It's already dead. Okay, so this is how we would use that to kind of assess myocardial perfusion. We can tag red blood cells, something we call a MUGA scan, and we can actually watch and trace blood as it moves through the heart, and actually get good calculations of cardiac output, for example. It help us localize, and quantify ischemia and infarction, as I've kind of just mentioned. You can actually get a look at the area there. We can also take a look at metabolism, which is really interesting. So that's the PET scan I mentioned earlier, the positron emission tomography. And so PET scans can actually also assess myocardial perfusion. So it can look at areas that have cold spots versus spots that fill in. But it can also use a glucose analog. The glucose analog is fantastic because what it does is this is a tagged glucose, and what we need to understand is that under normal circumstances, cardiac myocytes prefer fatty acids for energy. So 80% of its energy usage comes from fatty acids, and about 20% or so comes from glucose utilization, and that's under normal conditions. So there would be some take-up of this glucose with the normal cells. However, with damaged myocardium, the myocardium is still living, but it's damaged or ischemic. That ischemic myocardium will actually switch to more glucose utilization, which means that in this case, if I have tagged glucose, the highlighted areas in a PET scan that are taking up the glucose are really indicative of the ischemic areas. They'd be more damaged. So I could actually combine the two. I could see, a cold area that's taking up more glucose. So that's, so I could combine different types of imaging modality. I could say, all right, well, we'll take a look at, perfusion, and I see a cold spot, and then I use the glucose, and I see that it's taking up the glucose in that area. That would make sense to ischemic tissue that's going to be utilizing more glucose but has poor perfusion. So that's something you could use to help you kind of figure out what's where the tissue is that's being damaged, and whether or not we can try to rescue that tissue or not. All right, so catheterization. So this is another common one that's used by many hospitals. Something you might see in, say, the ICU. It's also used for surgical purposes with like coronary angiography, for example. And so I started actually with this picture here of Eugene Stead, who is actually the founder of the PA program. And I think it's an interesting bit of history because in the 1940s, he had established this, and he also paved the way for a lot of what we currently use for catheterization. So he was sort of an integral part of how we use catheters now. And so we can actually use these catheters, which are basically these very thin tubes, and they go, they can be inserted into a vein or an artery, and we can essentially, move them or snake them through the vasculature and into the heart, And there we can actually carry out different tasks. So for example, we could measure pressure. So as you can see in the cartoon over here, let me draw it for you. So over here, you see in the right atrium, you can see the tip of the catheter there, and it can be connected to a pressure transducer. And so with that pressure transducer, we could record pressures in the right atrium and see if pressures have been elevated. In certain forms of heart failure, you would expect pressures to be elevated. If you have elevated right atrial pressures, that might be causing things like edema and JVD and so on. But you can see down here, this will be the normals. You can see the right atrial pressures during systole and diastole. All right, the diastole would be close to 0. Systole might go up to about 5 or 6 millimeters of mercury as it's contracting. And then if you move that into the right ventricle, you can see the pressures, the diastolic pressures are still around 0 because when the right atrium is open to the right ventricle, they essentially act as one chamber, and it's going to be about the same. It's going to be about 0. And then you have here systole. You see that the peak can go up to about 20 to 25 millimeters of mercury. And then as you move the catheter into the pulmonary artery, you'll see that the diastolic pressure is right around 10, so the diastolic pressure has gone up, and the systolic pressure is about 25, which is matched to the right ventricle. Now, oftentimes we refer to this as a capillary wedge pressure, because what happens is you can take this capillary and you can continue to move it into the pulmonary vasculature until it gets to a capillary where the diameter is so small that the catheter actually wedges in there. So it gets in there, and on the very tip of the catheter is a little inflatable balloon too. So you can actually inflate it, and it compresses the surrounding wall around it. What that does is that basically occludes any blood from going around it. So it blocks it off, kind of acts like an embolism there, or not an embolism, but it blocks it off and includes it like a thrombus. And downstream of it, now it's connected to a cylinder of blood that's connected to the capillary, the venous, pulmonary venous system, and to the left atrium distally, because there's no valve separating the capillary from the left atrium. So it's basically now connected to a column of fluid that's from the capillary all the way to the left atrium. And so it can actually measure left atrial pressures indirectly in that way. So it's not directly in the left atrium because it gets wedged there, which you can see in that last box. But because it inflates the balloon and just creates this column of fluid from the capillary all the way to the left atrium, it can actually give us left atrial pressure changes, because those would be transmitted retrograde as well. And if the mitral valve is open to the left ventricle, it could actually give us an indication of left ventricular diastolic pressures as well. So oftentimes when you see a pulmonary capillary wedge pressure, they're being used to indicate what the left-sided pressures are, particularly the left atrial pressures. We can actually use catheters to measure cardiac output. They can use different techniques to do that. They can be used to calculate resistance, so we can find out about pulmonary hypertension. It can also measure oxygenation, so we can actually check the status of the blood and how oxygenated it is in the different chambers. This is useful, especially if we have shunting going on, right? So for example, I may have an increase in oxygenation as I go from the right atrium into the right ventricle, because the left ventricle is moving oxygenated blood into the right ventricle through an opening in the ventricular wall. So it could tell me about changes in oxygenation. Contrast, I can eject contrast and get good structural identity of the different chambers of the heart. I could use the contrast injected into the coronaries and use that to actually look at if there's any strictures in the coronary vessels. So I could evaluate them for possible stents and reopening procedures. And in fact, this would be the gold standard for evaluating the coronary vessels, because the echo, although very useful and non-invasive for the most part, can't evaluate the coronary can't evaluate the coronary vessels adequately. So this would be required for that. So this is just a cartoon showing the coronary angio. So this is the catheter that's snaked up through the artery, probably through the femoral. You can see there. And as you can see, as it moves all the way up from the leg artery around through the aorta, and then right at the base of the aorta there, where it's connected to the heart, just above the valves, you have the opening to the coronary vessels. And so you can see in this image here, the coronary vessels as it ejects the dye, and the dye moves through the coronary vessels during diastole. It'll fill up nicely with that contrast. You'll see that there could be certain areas that might have strictures, and then that would be the areas that, of course, we might approach to help, to stent or to do something of that nature to open up those vessels. So again, here's just another imaging of the coronary angio, where here you can actually see an actual image of the angio. In fact, you can see some of the dye filling up the base of the, let me change my color here, the dye filling up the base of the aorta there. It's going in through the coronary. And you'll notice there's nothing over here. And then after revascularization, you can actually see it open up this entire vessel here. All right, so that opened up the complete blockage. So again, this is the gold standard for diagnosing the coronary artery disease. And again, it can be combined with actually adding a stent or using a balloon to pop open a constricted area. CTs and MRIs can also be used in evaluation. Their role overall in evaluation is still being assessed. But you can use the CT scan, which is using multiple thin slices of X-ray that move around the patient and gives us sort of a cross-sectional view. Whereas the chest X-ray that we showed like an anterior, posterior, or a lateral view. This can give us actually cross-sectional views in high detail, and we have different types of CT modalities that we can use to give us better imaging. And you can see over here, so this is the CT. They can often be used with contrast, which helps us to light up the vascular tree, because again, X-rays are using density. So if we want to be able to look at the blood, for example, more specifically the vasculature, we can, or the chambers, we add contrast. That's going to help to separate that from the other structures that might be of closer density. And so what you can see here is actually in this sectional view here. Over here, these two are actually connected to each other. And just to kind of orient you, you're looking at, here's the spine. You can actually see some of the scapula there, or I should say the vertebrae, and here's the scapula. So that's the patient's back. You can see some of the ribs here, which are very light. Okay. And so where this section is taken this is actually more out towards the apical side of the heart. Keep in mind that when you're looking at a CT, especially with a cross section like that, it's as if you're looking from the patient's feet upward. Okay, so if you're looking from the feet upward, that would make this the patient's left side, and this would make this the patient's right side. All right, so it's as if they're laying on the bed, you're looking up their feet. And so here, this is actually the pulmonary trunk, and you can see the pulmonary arteries with the contrast in there, so we can see it. Okay, you see over here, this is actually the aorta. And if you recall, the aorta, as it comes up, it goes up above the heart, so it'll be coming above the heart and then down. So this is the descending part of the aorta over here. And what you can see here is this, it looks like there's two lumens. There's like one here and there's one here. All right. That's actually depicting a dissection, which we'll talk further in another lecture, but that's actually showing you a dissection where the intimal wall of the aorta is actually coming off, and it's creating what we call a false lumen. And so we'll talk about sort of the details of that a little bit later, but the point I'm trying to make is that the CT can give you good information about the aorta, things like dissections, aneurysms, right, where you have enlargements of blood vessels, as well as aneurysm of, say, the ventricular wall. We can use, this helps us to also assess coronary arteries. It's not as good as the coronary angio, but we can see if anything is calcified. So if somebody has atherosclerosis, they might have calcifications, which would show up more whitish. MRI is, gives us even clearer pictures. It's not using density. There's no radiation as there are with CT or X-ray. It's using instead a magnetic field. And in that magnetic field, we can get really, really clear images of the anatomy. So we can see really adjacent structures very well. It's very good for looking at different pathologies of, say, the myocardium versus the pericardium or the endocardium. It can also take a look at the anatomy of the coronary vessels via a process called an MRA, which is just using magnetic resonance angiography. It doesn't actually require contrast, which is interesting. unlike the CT, which would require contrast to be able to see some of the blood, in the MRIs, laminar blood flow or smooth flowing blood actually shows up bright on an MRI. If there's an area of turbulence, which would occur around, say, a stenotic vessel, when there's a stricture, you could have turbulence. And what ends up happening is that shows up as a loss of that intensity, so it shows up as sort of blackish, and that could be an indication of stenosis or a turbulent area. And so you can kind of see that over here. You see a little, kind of looks a little darker there. So again, that's showing you that it's turbulent in that area, which would correlate with constriction. And so you can get 3D renditions, which are really great, which you can see over here in B. Here's the CAT scan version over here. And then you can see over here, D right here, that's actually our angiography. And it's just trying to show you the correlation between those, how it did pick it up on the MRI there. And you can see it on the angio, but the angio is much clearer. MRIs can do use contrast as well, something called gadolinium. Gadolinium can actually be used to assess ischemia. It's not often used, but what can happen is the gadolinium is not taken up by healthy cells. It can be taken up by damaged or dead tissue. I shouldn't say taken up, but it basically can leak into those areas, and so gadolinium can highlight the ischemic areas on an MRI. Pacemakers we'll talk a little bit more about during the arrhythmia section, but basically pacemakers often used for somebody with bradycardia, with symptoms, somebody who has a heart failure, any kind of a heart block or conduction block. And the idea is to basically make sure you can maintain the pace, and if they're permanent, they can be inserted under the skin, and the electrodes themselves can be snaked into the heart via the venous system, go into the right side of the heart, and actually make contact with the heart wall. And they're very very intricate in the sense that there's feedback to this device here, the pulse generator, and if the heart goes too slow, it can cause it to elicit a pulse to keep it going. And they can be set and monitored, and there's many different things that you can do with them, and they can be very useful. In some cases, they may even have defibrillating action, which can help rescue some patients with heart failure from going into fatal arrhythmias. Common labs, we'll talk a lot about these as we kind of go on, but things to kind of assess cardiac patients in general. You want to check the lipids, cholesterol levels and all that, because that's going to be involved in things like atherosclerosis, which is one of the major contributors to heart disease. Glucose as it pertains to diabetes, and diabetes is definitely one of the main contributors to cardiac disease. Troponins and CKMB with acute heart pain to assess any kind of cardiac tissue death or damage. And electrolytes, potassium and so on, that can cause arrhythmias, and calcium and so on. Complete blood counts to figure out whether or not we have an anemia going on. White blood cell count if there's an infection, like an endocarditis type picture. ABGs might be necessary to evaluate oxygen levels and pH. Blood cultures, again, if we're thinking maybe something infectious. Drug levels to assess therapeutic levels for something like maybe digoxin or an overdose of some sort. Urinary output, in cases of heart failure, urinary output may go down. In cases of shock, their urinary output might go down. So these would all be things that we're going to see as we go, that we're going to use as assessments moving forward. Lastly, these are just cases that I want you guys to look at that we're going to review together in person. But this pertains to the case that we started with. So I gave you guys a little bit of the history, a little bit of the presentation, the symptoms, and the physical exam, and this would be some of the imaging that we had. All right, and unfortunately, this is supposed to show motion, but just to give you an idea here, this is left atrium, and this is the left ventricle, and so we need to know what that valve is. Okay. And so this is sort of a thickened, what they call a hockey stick valve. So I'll give you guys kind of that much information. This would be the patient's chest x-ray. Again, this is a made-up patient, so this is kind of pulled from different things, but this is the patient's chest x-ray, so I want you guys to evaluate that. And then finally, here's an ECG. We haven't gone over ECG. I know that I don't expect you guys to be experts on it, but I want you guys to take a look at it and see what your thought process is. So I look forward to talking to you guys about this in person, and or at least over Zoom. Take care.